And so that's a view from outside the ministry. Why don't we go to Fredrika at this point? You can see how these things are starting to knit together, and hand it off to Fred.
Sure, thank you. Thanks, Bill. So great, I get to give the payer perspective here. We've heard from industry and from providers, and so that's, I think as you say, Bill, we'll start to knit a picture together. I have a long and awkward job title, as Bill expressed and read out to you, but really I think I can sort of sum it up as I help Bill unplug the faucet, or the drain, the funnel. The funnel. So I have another hand on the bottom of the funnel there with him. And I do want to speak to, so I have a sort of double-barreled title, right? HKO Liaison and Program Development. So I want to speak from my experience in sort of both halves of that portfolio, but what it's like on the payer side in terms of trying to introduce and support adoption of innovation within the payment system in healthcare. And really about how to enable payment models that support innovation broadly. We're thinking not, as Alexis noted, there are some innovative models that will work for some programs, but we also have to think about broadly how healthcare is funded and how we can start to shift a larger ship around. So I want to talk about, first of all, HKO Liaison. Part of my work there is I work with the both sit on and work with the Ontario Health Technologies Assessment Committee, OTAC, which is supported by Health Quality Ontario and does a number of health technology assessments and makes recommendations to government about which new services, devices, technologies we should fund in the system. And that really is an experience from a payer perspective of receiving a funnel of innovative services and new devices, new technologies that should be funded, and the challenge of absorbing what can be often or are often disruptive technologies, disruptive to current program models, disruptive to business models, technologies into our system and adapting our program models to fit them. One of the things that has struck me in that work is that we are often engaging with industry, with providers a little too late in the process. So I think, Peter's point about government support is critical, but it also, to me, it means not just that a payer comes in at the end of an innovation cycle and says, yes, okay, we'll pay for that service. We actually need to be engaged upfront and early about what is coming forward, what is it likely to disrupt, what business models and what program models is it likely to disrupt, and how can we be sure that it's not diffused before we have the evidence, or as it diffuses, we gain the evidence that we need to make what are often very significant policy decisions to adopt it provincially. I'm going to speak to a couple of examples. At the risk of being a little controversial, I'm going to talk about robotic surgery. And anyone who wants to talk with me about robotic surgery can do so after the meeting. I'll be here. We recently received a recommendation from OTAC to not fund robotic surgery for robotic surgical systems for prostatectomy in the province, which is appreciably a very controversial recommendation, given that this technology and this procedure, this service, has diffused within the system already to a certain extent. There are a number of hospitals already offering that service to patients in Ontario. And the challenge really, I raise it just to say, this is one of the challenges we face as a payer when diffusion has happened in advance of the generation of evidence and specifically the generation of evidence on patient-important outcomes. We don't have at our disposal, and the reason that OTAC was unable to make a positive recommendation in this case is that there was not Ontario's solid evidence that we had, at our disposal on that robotic surgical systems or robotic-assisted surgery provides better outcomes for patients on measures that are meaningful to patients. And there is clear evidence that it's a significantly more expensive technology or a service than open surgery. So as policymakers, these are the things we're weighing. And we are, and I guess I should say, what's challenging again as policymakers, there is a funnel coming in of all kinds of new things we could do, we could pay for, and almost inevitably, it's a trade-off decision as a policymaker about funding X at the expense of Y. There's almost no context I've been in and I've been involved in as a policymaker in which electing to pay for surgical systems isn't at the expense of something else within a capped health budget. So that's just to say, we think we need models of engagement with industry and with providers that would enable us to be further up the innovation cycle, understanding that robotic systems are coming forward, understanding that this really is the way that surgery is going to go, even if we don't have the evidence to suggest we should pay for it broadly now. What are the program models we can work on collaboratively with industry for example, for coverage with evidence or coverage with outcomes, kinds of arrangements, so that we can work with industry and work with providers on that diffusion rather than playing catch up at the end. So that's what I want to say about robotic surgical systems. But as I said, happy to debate the finer points with anybody. Another example, I would say, we're seeing enormous energy, enormous innovation in industry around home monitoring. So this is really around bringing the care out of the hospital, empowering and enabling patients to monitor their conditions at home. And as we think about the needs of our healthcare system going forward, if we think about people living longer with multiple chronic conditions, there's clearly a need for us to engage with industry early on the value to patients of things like implantable cardiac devices or home monitoring systems for heart failure, for COPD. This is, as I think about our opportunities, our opportunity is to think early about what are the models that will enable us to bring these kinds of technologies into our system. And these are not likely to be hospital-based systems or programs. This is really how can we empower patients in the community to manage their conditions better and avoid hospitalization and much higher downstream costs in our system. I don't have answers there, but one of the themes today is what is the value? How can we center and focus collaboratively on value for patients? Here's one area that we know there is opportunity for value for patients if we can create the right payment models that incent both providers and industry to develop care models and track the outcomes. But I also wanted to bring some perspective from the other half of my portfolio. So part of my work is, as I said, working with Health Quality Ontario and acting as a receptor for the evidence-based innovation that's coming through that organization to us and the recommendations that are coming to us as a payer. But the other half of my portfolio is developing and managing a set of innovative funding programs which are intended to align payment with quality and outcomes. And so in this realm, we have been working in the hospital context with quality-based procedures. So I would imagine a number of you are familiar with quality-based procedures, and I know a number of you have worked directly on them with us. This is, I should say, an activity or a volume-based program. Let me not create a false understanding in the room. We're not yet at value-based payment here. We want to get to value-based payment. Part of the journey we've been on in health system funding reform is a shift from what have been historically global hospital budgets to a blend of activity, volume-based, and global budgets. Where we think we need to go is a focus on value. And I'll talk about QBPs and the evolution of that program in terms of how we want to get there. So we know that quality-based procedures, which are essentially an episode payment, we identify an area or a service or an area of care where we know that there is Local area variation suggests for us there's an opportunity for improvement. We engage with clinical experts who create clinical best practice guidance, and then we fund the episode of care within the hospital walls, typically, for appropriate set of patients. And we manage that on a rate by volume basis, and we track the clinical quality metrics that are associated with that, with high quality care for that patient population. So far, so good. We've been able to both increase access, and we've been able to increase some of the clinical, or improve, I should say, some of the clinical quality outcomes that we want to see through those QBPs. And we've been able to introduce innovation. So again, I guess an example I'd point to there is endovascular treatment for stroke, which is again a relatively recent technology or procedure that we've been able to integrate into our episode payment model for stroke care in the province. What we're not doing yet, to be clear, is actually directly linking the payment, our payment for an episode of care, to the outcomes that the patient receives for that care. And we're not yet directly linking the payment, the amount we pay, to outcomes from a patient perspective, outcomes that are important and meaningful to patients. And so I do want to talk about the direction we're moving there, and our aim to get there. We have, in the last couple of years, been expanding the quality-based procedures program to follow the patient episode throughout the full journey of care. So we have been expanding beyond the hospital walls and piloting bundled care models in a number of service areas. So 6 pilots have been underway in the province in stroke care, cardiac surgery, heart failure, COPD, cellulitis, and UTI. I'm hoping that I didn't miss any. They've been piloting a model of care that enables a care team to follow the patient from the inpatient episode and back into the community in post-acute or post-discharge rehabilitative care for a period of 60 to 90 days, enabling that care transition to be smoother, patients to return home to their families sooner, but supported by consistency in the care team. We're finding across those pilots, the teams are able to reduce readmissions, reduce ED revisits after discharge. Patient experience is extremely strong, and so is provider experience. So one of the interesting things about this model is that hospital providers and surgeons in particular, so to speak to the cardiac surgery example, the cardiac surgeons working in the model are more confident about discharging their patients more quickly back to the community because they're confident about the care team that will be caring for those patients in the community. They know that they'll have, that there's 24/7 monitoring and support, phone line offered to those patients, and that any issues in that patient's care will be relayed to them very quickly. So it's been, I would say, a care model that's been so successful in pilot that we're very confident about rolling it out further, and we are moving to scale this year on a hip and knee replacement bundle and have offered that opportunity to all hospitals in the province. But as I said, we're still talking about...
So you know that the music's going to start, huh?
I'm almost done. We're still at the point, I think, of paying for activity here. But one of the important things as we move to scale, and I think about the presentation from ICHOM earlier today, is that we will also be requiring from hospitals and community partners that participate in the bundled program that they track and report standardized patient-reported outcomes for hips and knees that align with our national comparators through CIHI and also align with the ICHOM international comparators. And as I think about the direction of the program, this is really where we need to be moving, to not only identifying the evidence-based care and making the payment, but ensuring that we're tracking the outcomes in a way that's comparable within the province, nationally and internationally, and over time, beginning to link directly the payment to the outcomes that are received.